I would think it's a sad point.
Great. Thank you for that.
Great comment. Let's move on with Anand's case. Thank you so much, Caroline. Fantastic case.
Thank
There are more interesting things than CSR.
Can you
All
see
right.
slides, Jay?
Yes, please. We can hear you well as well.
Okay, so it's a pleasure to present this case, a 56-year-old male who presented to us with painless progressive diminution in vision of the left eye of 3 months, was a diabetic, hypertensive, and cardiac patient under treatment. Best corrected acuity in the right eye was 6.6, left eye 6.12, was a non-smoker, did not use steroids of any form, no similar illness in the past. Now, fundus examination at presentation showed dominant finding was macular subretinal fluid. Drusenoid changes seen more in the left than the right eye. You can even call them pachydruseness. I'd like you to direct your attention to these faint but definitely discernible choroidal folds, and we'll talk about that and their significance in a bit. The OCT showed macular subretinal fluid in the left eye and peripapillary skytic intraretinal fluid in the outer retina. Was definitely pachychoroid in both the eyes. Fluorescein angiography ICG showed the hyperpermeable foci, pachyvessels on the ICG. No definitive classic CSCR leaks. Staining of the drusen and choroidal folds were also seen on the angiograms. We believe this was an open shut case of pachychoroid with left eye CSCR. Photodynamic therapy was done to the hyperpermeable foci. And 1 month post PDT, there was a very satisfactory resolution and acuity improved to 6.6. You can see the macular SRF as well as the intraretinal peripapillary fluid has abated. But surprisingly, 3 months later, there was a significant increase in the subretinal fluid, in the macula, in the peripapillary area. There was alarming optic disc edema, and vision had also marginally decreased to 6.9. And we believe we were looking at what was an incipient case of uveal effusion syndrome. So the fluorescein angiogram showed a florid disc leak and the B-scan, a very severely congested choroid. The axial length checked out to be, both eyes to be about 21 millimeters. UV profile was normal. So we had no hesitation in calling this now uveal effusion syndrome. And considering that it was incipient UES and there was this alarming choked optic disc, we went in with the injection intramuscular dexamethasone as well as intravitreal dex. And it was also based on the paper by Shields a few years earlier where they showed a successful treatment of UES with steroids. The post-injection day 1 patient was symptomatically better and remained so for a week. But worryingly, subsequently, a few weeks later, patient's vision dropped to 6.36. There was progression of the UES and with significant subretinal fluid. There was disc edema increasing. There was definitely increased choroidal turgidness, as you can see on the OCT. Exudative RD was seen inferiorly. Peripheral, almost 360 degrees choroidal detachments, leading up to almost imminent angle closure with rising intraocular pressures, mandating up to the point of YAG PI. So we had no hesitation now in offering the patient subscleral sclerectomy, which is the standard for UES. Patient opted to wait, unfortunately, and was lost to follow-up. Then when the patient did come 3 months later, we were delighted to note spontaneous resolution of this uveal effusion syndrome. This complete resolution, as you can see, of the SRF and detachment, a leper spot, retinopathy was seen almost. The vision had dropped to 660, but that was because of the cataract. And you can see on the ICG, these pachyvessels almost swarming up to the macular area and in fact culminating at that atrophic PDT treatment spot. So post-cataract surgery, the vision improved from 660 to 612, and the patient had been stable thus for a year. So the unique features of our case was basically CSCR morphing with uveal effusion syndrome, features of pachychoroid in the uveal effusion syndrome, and spontaneous resolution of UES, prompting us to offer a pathogenesis postulate that UES may lie at the extreme end of the pachychoroid spectrum. So most of what we know about the uveal effusion syndrome comes from the stellar work done by Uyama and colleagues, where they profiled the disease beautifully, looked at the management options, and gave us this great classification. So we believe that our case was probably type 2, maybe type 3. We didn't really get to do a sclerectomy, so we couldn't really make an absolute thorough assessment of the sclera. It was not very definitely taken on the imaging. Going forward, as we know, where the pathogenesis, the sclera and its impermeability is implicated alongside congestion of the vortex veins as fluid accumulation, and a dysfunctional RP pump leads to subretinal fluid accumulation, along with the mismatch between hydrostatic and colloid osmotic pressures. So why steroids? That's a valid question. So Shields in their paper in 2017 looked at 104 eyes, all of which were type 3 UES. 95% of them improved with steroids through different routes. Only 5% went in for sclerectomy. And the mean axial length was about 22 millimeters, somewhat similar to our case, which is 21 millimeters. The role of steroids, the mechanism of action they suggested was reducing inflammatory factors and control of this transudation via membrane stabilization. So a few citers for this nexus between UES and pachychoroid. Well, there's an interesting paper and stray reports have been there in literature, but this anecdotal report is a shot in the arm for this theory, where Venkatesh et al. Showed in the case of definitive chronic CSCR with a large PED with fibrin around that with inferior exudative detachment, they did not have CDs or disc edema, and therefore they did not call this uveal effusion syndrome. They just called it as chronic CSC with inferior RD. The axial length was 21 millimeters. Like our case, they went in for a partial thickness sclerectomy with mitomycin C, and they found beautiful resolution of the case. So short in the arm. And a little while later, George, my brother in arms for CSCR, will also show an excellent case, which is similarly, and I won't steal his thunder by talking more about it. But there have been more cases in literature, straight reports, which have added credence to this theory that UES and pachychoroid may be linked. More recently, as Rishi has pointed out, the vortex vein theory promulgated by Spade and workers, and also by Matsumoto, as mentioned, in his Spade's paper, that the different forms of pachychoroid CSC, peripapillary pachychoroid syndrome, and pachychoroid neovasculopathy. Everywhere in all these, they found that that the segmental nature of the vortex vein is lost. Anastomotic channels, which perhaps can be called pachyvessels, they trespass the sacrosanct horizontal watersheds. And these anastomosis in CSC and PNV are obviously seen intuitively more in the macula. PPS is obviously around ONH, and the increased adjacence leads to CSR. And what we suggest is possibly a harbinger of UES. Vortex, as I mentioned, congestion is central to the pathogenesis of UES anyway, and decompression of the vortex is anyway one of the theories which were offered. Our case, as you can see, as I'd just like to reiterate, we could see the swarm of pachyvessels or anastomotic channels coming from the inferotemporal vortex vein system, and perhaps anastomosing with the supratemporal one. So in summary and points to ponder, in our case, setting was a predisposed eye, 21 millimeters, typical pachychoroid, but importantly, there were choroidal folds to be seen. CSR was there with choroidal hyperpermeability, responded well to PDT for a month, then slowly developed disc edema, UES, and subretinal fluid with good vision initially, 6/9, which prompted us to do that steroid trial based on the Shields paper. Was fine for a week or so, and then unfortunately over a week developed full-blown UES with CDs and inferior exudative RD, subscleral sclerectomy advice, but not done because of lack of follow-up. Spontaneous resolution was fortunate to be had. And we believe the supports the pathogenous postulate that UES may lie at the extreme end of some pachychoroid cases. And what we believe is that there are learning points to be had, that in a case of pachychoroid, 3 things need to be looked at. 1, short axial length, 2, choroidal folds, and 3, on the ICG, vortex veins. So these should raise red flags and suggest that this case of pachychoroid may slide down the pachychoroid spectrum, go through CSR possibly, and may even end up with uveal effusion syndrome. Thank you.
Fantastic, fantastic case, Anand. Well, why don't we actually get George's case as well, and then we discuss both the cases together, because they share a lot of similarities. Is that fine, George?
Yeah, that's fine. Fine for me.
Yeah. Sure.